This is a physical exam on Mr. Calder, who we were speaking of. He's had left knee pain and a chronic ankle wound. We'll start just by ranging the knee, so we'll get him fully extended. Does that hurt you there, sir?
Not at the present time.
Okay, and then we'll bend here. A lot of times, especially with fellows that have been dealing with pain for a while, they'll be very stoic, so you even have to ask them, does that hurt? Because I'm surprised they don't wince or say anything. Their face doesn't change sometimes, and they'll say, yeah, it hurts a lot. So you really do have to ask, is that hurting you? And then you find the joint line. So you come up the tibia here to the joint space. You'll feel where it gets soft, and you'll feel the patellar tendon there, and or you could call it the patellar tibial ligament. I think of it more as a tendon, an extension of the quad tendon, because the patella is more of just a giant sesamoid bone within that tendon. But we find those landmarks, and we find where the tibia ends, and we find the joint space here real easy at this medial and lateral window, and then it gets narrow as we come around, and we follow that joint. Do you have tenderness there, sir? So not uncommon that we find more tenderness posterior laterally here and posterior medially here. That tends to be where we wear out more and have more degeneration, and often degenerative meniscal tears or even acute meniscal tears. These are the kind of the trouble spots along the joint line where you'll find that. And it sounds like you've got more pain over here than here, or are they about the same? Tenderness there, about the same.
Yeah, it gets a little sore over there.
And then while I'm there, I come back to the popliteal space. Are you tender back here at all?
Yes.
And so he's a little tender, and if they're tender in the popliteal space, most often in the absence of other symptomatology for DVT, that'll most likely indicate a Baker's cyst back there in the presence of degenerative joint disease. However, I continue to palpate down the calf approximately. Are you tender down in here?
Yes,
if I push there, does that hurt now or no?
It gets real sore
sometimes.
at times.
And when I push, does it hurt or not right now?
Well, sometimes it can.
Sometimes it's real bad. I got
touch
it.
it.
How about this? Is this bad or no?
I can feel it.
Okay. And so sometimes you need to differentiate, because people will want you to know that they hurt, but it may not be tender at the time. You kind of need to differentiate the symptomatology from the tenderness on exam. But in this setting, when he's got popliteal tenderness, a little tenderness there, diabetic adds to vasculopathy, maybe some stasis here. We see a little swelling. We'll check the size of the calf. Real easy. You can just check at the same level here, and we see about 1.5 centimeters between my thumbs there. And I do the same thing here at the same level, and I'm touching. So he's actually he's a good 1.5 centimeters, 2 centimeters bigger in circumference. So we've got unilateral swelling, popliteal tenderness. We really want to make sure he doesn't have a DVT. I would bet that he doesn't. I would bet that this is all explainable from arthritis and venous stasis. However, we're going to check, because we don't want to roll the dice on something that can kill you. So we don't expect that you've got a blood clot there, but we're going to check for that. Okay? Now, continuing on with the knee exam, I extend him and I just relax for me, try to just relax. And I get him to I say, give me the leg, and that usually people get that and they relax. And I give a little valgus stress this way, and he's got a nice end point, he's not laxed, and so both of those ways he goes good. And then we do a little anterior draw. We want this foot to stay right there, and we pull like so. When they have shoes on, I put my foot in front of theirs to block, but this is fine. And he doesn't have any laxity, ligamentous laxity on any of the valgus, varus, anterior, posterior draw stresses. And then we just inspect, and we see some trophic changes of the skin, and when I say that, I mean developmentally over time, you start to get these kind of rough elephant skin. Sometimes you can get some darker pigmentation. He's got a little reactivity in the skin here. And then we see this ankle wound here. This has been a chronic wound with some keratotic changes around the surface here, around the periphery. Certainly doesn't look frankly infected. There's no purulence, there's no fluctuance. And it doesn't have that angry cellulitic redness, just some mild pink inflammatory changes around here. And then we see this posterior wound is a newer one. I don't know if you can get that, Joe, but looks a little fresher there at the base of the wound. And when I palpate for a pulse, he's got a nice bounding 2+ pulse. Here is dorsal pedis pulse, so we know he's getting blood flow to the foot. Doesn't have any